Good night, everybody. We're sorry for being a little bit late. My name is Marta. I'm a radiation oncologist from Hospital Mulheres de Evento. I'm here together with my medical oncologist colleagues, Dr. Helena Andrade and Dr. Guilherme Gaib. And it's our pleasure to introduce Dr. Nargis Flores. She's a medical oncologist and expert in the field of non-small cell lung cancer in female patients. She works in the Dana-Farber Cancer Institute, and her clinical expertise and research focus is on the unique challenges faced by this group of patients. And this inspired us to do this event and invite her to be here with us today. I'm sure that we will all benefit from her valuable insights and expertise. And after her presentation, we will have a 10-minute break for questions from the audience. And in the sequence, we will discuss a clinical case. I would like to ask you to please pose your questions in the chat. And that's it. I think, Dr. Flores, thank you again, and let's do it.
Hi, everyone. Oi, boa noite. Tudo bem? That's as much as I'm getting better. Some of you guys know I'm working on my Portuguese. So I have a big goal is to give a talk in Portuguese fully by next year. So hopefully I can make it happen. All right. Can you let me know if you can see the screen?
Yes.
All right. So it's my pleasure to be here. We're going to talk about lung cancer in young women. Today, I saw a 21-year-old with newly diagnosed lung cancer. The number of cases are going up every year. And I want to talk to you about the challenges that we're not prepared for this. When I trained for lung cancer, it wasn't particularly young women. So why did I specialize in younger women with lung cancer? It all started with one of my patients when I was at the Mayo Clinic. She was diagnosed with metastatic lung cancer, a never smoker. And the first thing she told me when I met her was, this is a picture of her that I'm sharing with her family permission, is please do not tell my family. She didn't want her family to know that she had lung cancer. She was very worried about the stigma, about all the negative aspects that the disease had. It was 2 years that I treated her with EGFR positive lung cancer, and her family didn't know. And despite talking to a lot of people, palliative care, psychology, only her husband at the end of the journey knew that she had lung cancer. She was 38 when she was diagnosed, and she was 40 when she died. Something that changed my life forever was when her family sent me her obituary. The obituary is when you post in the paper when people die. And it said that she had died of breast cancer. She put it on her will that she didn't want people to know that she had lung cancer, and that in the obituary it should say that she had breast cancer. So that significantly broke my heart. And I went in this journey to study the disease and to support these women with this disease. At least once a week, I have a woman in my clinic that comes dressed up in pink that has lung cancer. The problem with lung cancer is there's a lot of stigma and people don't talk about it. And I think this picture exemplifies the issue that lung cancer is for young women. There is more women dying of colon, breast, ovarian, and uterine cancer combined. There are more women dying of lung cancer than any of those cancers combined. It's the most deadly of all cancers for women. And for never smokers in the United States, the Boeing 747, the biggest Boeing plane, 2 planes full of women that never smoke crash in the United States every day, of these women die. And in 2018, for the first time in history, younger women now are getting more lung cancer than men. And this is irrespective of smoking behaviors. More younger women between age 30 and age 44 are getting lung cancer than men, something that we haven't seen before. And unfortunately, something that we don't see in the news. There's a lot of lack of awareness. In 2019, we surveyed 1,000 women, random women, and asked them what was the number one cause of cancer death in women in the United States. Only 1% say lung cancer. There were other cancers like sarcoma that were more frequently mentioned than lung cancer as the number one cause of cancer deaths in women in the US. So there's a significant lack of awareness. On top of that, when we look at patients that haven't smoked at all, 2/3 of the never smokers that get lung cancer are women. So when we remove smoking as a bias, we know that lung cancer is a disease of women. And a lot of people wonder how many lung cancers are there in never smokers? Around 20% in the current numbers. 20% or 180,000 cases in the United States is still more cases than ovarian and cervical cancer combined. So it is common, we just don't talk about it. What about Brazil? Well, I found some of this data that was published by some people you may know that showed that the increased incidence and mortality rates of women with lung cancer in Brazil. And what we're seeing in Brazil too is that the female to male ratio, and you can see this in the lower graph, is going down every single year. So what we saw in the United States, we eventually happen in Brazil if these numbers continue, in which more younger women are going to have lung cancer than men, irrespective of lung cancer or smoking behaviors. And we know, as a Latina, we know that the incidence of smoking is significantly lower for women in Latin America compared to women here. What about mortality of women in Brazil with lung cancer? You can see that male mortality has slightly come down. And these are numbers all the way to 2014. This was published in 2018. I don't have any more updated data I was able to find. But you can see how the mortality is going up for women. And a lot of data shows that, yes, women started smoking after men. And that's what we see difference in the trend. But we also see in the increased number of cases that are related to mortality to never smokers. So lung cancer is killing our women everywhere. This is a map that shows the incidence of sex stratified by country for lung cancer mortality for women. You can see countries like China because of EGFR disease, Australia, the United States, Argentina, and some West Europe countries, they have a significant high incidence. Germany, for example. So this is a phenomenon that is not only to the US and Brazil. This is a phenomenon that's affected many countries. We do know that there are differences in mutations by gender. And this is a table we put together. This is still unpublished. We know that EGFR mutations are more common in women than men. KRAS mutations are slightly more common in women than men when all cancers are combined, adenocarcinoma and non-adenocarcinoma tumors. But besides this big frequency of differences in EGFR, besides HER2, I think the percentages are similar across mutations. So besides the EGFR, there is no significant mutation that's prompting more than another. So let's break it down to our women, right? What is it? No so mulheres and mulheres novas, I think, mulheres novas. EGFR is a big deal in Latin America. In Argentina, 15% of the cancer diagnosed in Hispanic women or women in Argentina are EGFR positive. In Brazil, 20 to 25%, which is higher than the United States. In Mexico, 25 to 35%, as well as Costa Rica and Colombia. And in Peru, 55% of the lung cancer diagnosed in women in Peru are EGFR positive. So we often talk about how EGFR is very common in Asian women, but the second group that is mostly commonly to have an EGFR mutation are Hispanic women. So why are we seeing so many increased cases? Well, there's many factors. We talk about tobacco, environmental exposures like radon. This is for a unpublished paper. This paper is publishing soon, so the image is unpublished. Air pollution, we see that significantly in Taiwan, China, for example, in India. Family history tends to be more stronger in women than men, particularly for EGFR germline mutations. And something that's very unique to women is they have a lot of secondhand smoke. So they don't qualify for lung cancer screening. Why do women have more secondhand smoke? It tends to be their partner who may be smoking, husband, boyfriend. It also, women for many years held positions in which they were exposed to tobacco. So they work in restaurants, they work at bars. I have 6 flight attendants that have lung cancer. They never smoke, but they were flight attendants when you can smoke in the plane. So they were exposed to years of secondhand smoke. And finally, radiation. I also have a cohort of patients that survived breast cancer and they received axillary radiation and now they have lung cancer. So that's very unique to women. These are breast cancer survivors that have radiation. Indoor pollution, big deal for women because the women unfortunately are most likely to be doing the tasks at home that include burning wood or burning coal. That indoor pollution or that exposure to biomass smoke for hours or years is one of the top causes of lung cancer in women in low to middle income countries. I'm working with a federation of the World Health Organization to educate the women, not to tell them not to cook, but to provide ventilation when they're cooking. What about other risk factors? We talk about breast cancer. The most common cancer after a woman has breast cancer and has been treated is lung cancer. Radiation and estrogens. We are continuing to study estrogens. The data has been mixed. We do know that patients that get diagnosed with lung cancer that are in hormonal therapy, we recommend that the hormonal therapy is discontinued or stop. These are other 2 risk factors that are coming down the pipeline. One of them is HPV. We know that HPV is related to cervical cancer and head and neck cancer. But what we do know also is that women take longer to clear the virus compared to men. So in this study on never smoker women in Taiwan, in which women are dying in Taiwan at very fast rates of lung cancer, these non-smoking Taiwanese women have significant higher rates of HPV DNA detected in the lung cancer cells. So 55% versus 27%. Also, there may be a relationship with mycobacteria. This requires even further workup because the sample size was small. But we know that there may be higher frequency of atypical mycobacterial infection in women with lung cancer compared to men. But that needs to be further investigated, but this is unique to gender. So what is Dr. Flores doing to study all of this? Well, in March of 2021, we launched the epidemiology of young lung, the largest study to date evaluating younger patients with lung cancer in the entire United States. We have so far interview and collected samples of 240 patients, women or men. And this includes a very extensive survey that goes to the patient and it goes to their mother, because we want to know if there has been any exposures when the patient's mother was pregnant. We evaluate risk factors, environmental risk factors, hormonal therapy to determine why is this happening. So this is a study that it's a 3-year study, so we're halfway done. All right, so everybody talks about lung cancer screening. So let's move to the women that do smoke or smoke in the past. What about lung cancer screening, right? Lung cancer screening saves lives. Well, not for everybody. Unfortunately, the National Lung Cancer Study trial that in the United States evaluated lung cancer screening in women significantly recruited more men, so 59%. But ironically, when we talk about mortality decrease for lung cancer, women benefit more, 27 versus 8%. What about the Nelson trial, which is the largest trial about lung cancer screening to date? Well, only 16%, you heard it right, 16% of the patients in that trial were women, and actually was an afterthought. They already had recruited a big chunk of patients, and somebody say, should we include any women here? And like my grandma say, karma, these women benefit more for lung cancer screening than the men in the study. But unfortunately, women are less likely to be offered lung cancer screening compared to men. And one study that we did here at NGH, women are 3 times less likely to be offered lung cancer screening, even if they qualify. Give me an example. We have a woman, and that woman that will qualify for lung cancer screening, but instead they get breast cancer screening. But the mortality benefit for a patient who's a current or former smoker is significantly larger with lung cancer screening compared to breast cancer screening. But these women are not offered that option. There's a lot of physician bias and gender bias because we don't see lung cancer as a disease of women. We see lung cancer as a disease of older men that has smoked in the past, and that delays the diagnosis significantly. And this is data from my own lab. Women of color, so Hispanics, Blacks, Indians, are 6 times less likely to be offered lung cancer screening. And if you're a woman with cough, shortness of breath, it takes twice as long to be diagnosed with lung cancer than a cross-match men that has the same symptoms, the same age, and the same risk factors. So gender bias significantly affects women with lung cancer. This is unpublished data that we just collected. But if you're a woman who has any symptoms suggested of breast cancer, it takes 2 visits to be diagnosed with breast cancer. For a woman that may have symptoms of lung cancer, it takes an average 6 to 8 visits to be diagnosed with lung cancer. So there's delays. These women are significantly delayed in diagnosis, and because of that, most of them are diagnosed with stage 4. So I'm going to hurry up a little bit, but there are additional challenges when treating younger women with lung cancer. One of the challenges is that this is a study that we published in 2018. The majority of the patients that go in lung cancer clinical trials from 2000 to 2016, these are all completed trials, were men. So 39% versus 61%. So what is the problem with that? The problem with that is that we have very limited data. And when we broke down these clinical trials and removed targeted therapy trials, which more women have EGFR mutations, we noticed that significantly around 1/4 of the patients in immunotherapy clinical trials were women. So we have something called enrollment fraction. This determines the cancer incidence and prevalence by the number of enrollees in a trial. So if you're a man, you have an enrollment fraction close to twice as much as a woman, 3.8 versus 2. So what is the problem, NJ? Why are you shaking the waters? The problem with that is that we end studies with this, like this. There's a study published by Dr. Conforti et al., and there's another study that has negative results, but that shows that women are less likely to respond to immunotherapy compared to men. There's several confounding factors. First, we know patients with EGFR mutations, ALK and RET, don't respond to immunotherapy. But these patients have negative mutations. So that confounder is out. And you can see it here in the graph non-small cell lung cancer, you can see how the woman, crosses the one with less hazard ratio. So there's mixed data, but the problem is we didn't include a lot of women in these trials. So a lot of the subgroup analysis are very small samples. What about side effects? Oh, I hope you're ready. So this is a study that we did at all the Mayo clinics, which was at Mayo. This is for anti-PD-1 therapy for lung cancer and melanoma. And I found that women were more likely to experience immune-related adverse events compared to men, 48% versus 31%. This is all immune-related adverse events. And we also saw a trend about grade 3 adverse events. So women were most likely to have grade 3 adverse events. And when we look at those side effects, we notice that women were also most likely to have very complex side effects. Diabetes type 1, myositis, pancreatitis were more common in women compared to men. And something that I didn't like that we found is that these women were most likely to go on steroids. And I think that has to do because a lot of these patients had very complex immune-related adverse events, like diabetes type 1, cerebritis. And we didn't find no other characteristic besides sex, biologic sex, to increase the risk of immune-related adverse events in this large cohort from the Mayo Clinic, the 3 Mayo clinics. And we do know that there is very little efficacy in patients with EGFR mutations with immune checkpoint inhibitors. So that's why it's so important to test younger women for biomarkers. And liquid biopsy is not enough. You need to get tissue because there is no response. And on top of that, there is a cross toxicity because if you start the patient in immunotherapy and then it has to go to a TKI, then there's significant cross toxicity or pneumonitis. That's why these women need to be tested and put it in the right therapy the day of diagnosis. On Monday this week, I saw a younger woman that was done a liquid biopsy, no tissue, and was put in ipi and nivo immunotherapy. And I tested the tissue, and now she has an EGFR mutation. What I'm going to do when we need to do a washout period. So this patient needs to be off therapy at least 6 weeks. So she may have to get chemotherapy in the interim because the risk of putting her in the TKI after the immunotherapy is too high. What about side effects? This is some of the data from my lab and other data published by other people, is that women are most likely to have neuropathy from paclitaxel. They're most likely to have nausea or vomiting from platinum-based therapy, and they require a more aggressive nausea control. They also are most likely to develop diarrhea versus constipation. And joint-specific side effects with immunotherapy are more common in women. Somebody say, maybe because women complain more than men. Well, I think it's very hard to, when you are measuring something as specific as bowel movements per day, to say that reporting bias. There is something about reporting bias that women may verbalize more than men that always needs to be taken into account. We also studied sexual health in women. In this large study that was presented at the World Conference on Lung Cancer last year, and then it was in the press conference for the conference. This is the largest study to date evaluating sexual health in women with lung cancer. And what we found was extremely sad, and it's that 77% of the 250 patients that were interviewed had moderate to severe sexual dysfunction. And there were significant differences before lung cancer diagnosis and after. Another thing for young women is fertility. These women need to be given the option of fertility preservation regardless of the stage. So sometimes you find me calling the fertility doctor and then calling the surgeon, because it's very important that now we neoadjuvant therapy, that these women are given the opportunity to preserve their fertility. We did a large study, this is breast cancer, to understand fertility and pregnancy-related issues for young women with breast cancer. And this is breast cancer, which is way ahead of lung cancer in this aspect. And we find out that most of these patients were not receiving counseling. So some breaking news here. And ASCO has agreed to fund my study called the Finch study. So the Finch is a golden bird that is science of fertility. We're going to study the effects of fertility and sexual health or immunotherapy in patients with lung cancer and melanoma. So stay tuned. It's going to be a large study, but we're going to do it. Something unique to lung cancer is the stigma with the disease. And younger women have more stigma because they don't know anybody else who has cancer. They don't know anybody else who has lung cancer. So it's significantly associated with higher rates of depression, anxiety, isolation, and very poor patient-physician relationships. And that's why so many women lie about their cancer. Also, as a young woman with young children, lung cancer comes in a time that completely disrupts their life. In addition, it brings a lot of financial toxicity. A lot of these women are in targeted therapy that is extremely expensive. Like today, I have to call a patient to tell her that she has to pay $900 a month, despite everything we try for her to get her therapy. A lot of these young women don't have savings. They don't have a backup plan, right? They're not expecting to get diagnosed with such a horrible disease at their age. I have to tell you, I think 40% or maybe more of the patients that come and see me in the clinic, they're younger women. I think deep inside, they're wondering if everybody was mistaken and they don't really have lung cancer. And when I confirm that, I can see how their little hope just disappears. Because sometimes they're like, I'm going to go to Harvard. I'm going to see the doctor that sees younger women, and she's going to tell me I don't have lung cancer. But it can happen. Also, we don't know their psychosocial needs and financial needs because many studies were done in older men. So currently at Dana-Farber, I have the Young Lung Cancer Study that started recruiting a month ago. And we're evaluating the prevalence of anxiety, depression, the financial impact of lung cancer diagnosis and treatment, and how they interact with the healthcare system. I promise I'm almost coming to the end. And something that we cannot forget is the role of women, family, and cancer. When a woman is diagnosed with cancer, not only affects that patient, but it significantly increases the chances of child mortality. If the woman dies or suffers from lung cancer or any cancer, it affects the children's education. It decreases the socioeconomic advancement of the family. It affects elderly care. The women are most likely to provide care for their parents, and a significant impact in healthcare workforce. Who are the majority of the nurses? They're women. So we are part of the Lancet Commission on Women and Cancer. We just submitted the first report today. So stay tuned for this report in which we discuss extensively the effect of cancer in women and society. And to finalize, this is how lung cancer looks like. Besides the patient in the middle with the x-ray, all of these ladies are my patients. I asked permission for them. Katie, the one with the white shirt, she's not with us anymore. But the other patients are here, and the one in the bottom was diagnosed when she was pregnant with lung cancer, and that's baby girl that now is around 6 months and she's doing well. But the time is today to improve the awareness. But this is how lung cancer looks like. Thank you, everyone. I think I stopped sharing the thing.
Thank you for the great talk. I don't know, I think in order to keep up with the predefined schedule, we could pass to the clinical case. What do you think, Guilherme?
Yeah, sorry I took too long.
No problem at all. I think we can leave the questions for during the presentation, and it will be fine also.
Okay, I will share with you my screen.
Thank you again.
Can you see the slides?
Yes.
Okay, thank you for the confirmation. So we will present a case that shows very much of you just show us. This was a 40 years old female without a history of smoking, a mother of a 6-year girl that came to our emergency department due to an intense back pain when she was 26 weeks pregnant. On the evaluation, the first exam that was done was MRI of her spine that showed a collapse of her first lumbar vertebrae due to a metastatic lesion. In the follow evaluation, the chest MRI showed 2 nodules, one of them in the left upper lobe and a bigger one in her right lower lobe. Also, she had a small nodule on her left brain hemisphere. So the evaluation went on. She had anemia, a serum proteinogram with a monoclonal peak in gamma globulins. This led her to a bone marrow aspirate and biopsy. And the results showed infiltration of the bone marrow by a carcinoma with TTF1 positive. Also, a transthoracic lung biopsy was performed and disclosure an adenocarcinoma also with TTF1. So the diagnosis was a metastatic lung adenocarcinoma in this pregnant woman. This case was conducted to a multidisciplinary tumor board. The neurosurgery team opted to the conservative management in the first moment. The obstetric team planned a cesarean delivery when she was 32 weeks of pregnancy. At that moment, she was 27. And we ordered a molecular test, and we decided that she needed immediate systemic treatment. She was symptomatic, she was with an infiltration of her bone marrow. And at this moment, I would like to ask you, Dr. Flores, what regimen of chemotherapy you choose at this moment? Our option was for carboplatin and paclitaxel, but would you mind something else?
That is my treatment of choice because we cannot use pemetrexed because pemetrexed inhibits vitamin B9 and B12 and affects the neural development of the fetus. So we can do that. But carboplatin and paclitaxel has been safely used in breast cancer, women pregnant. So that is you did the right treatment. That is our choice here for women because they're very big molecules. So we hope that it's not that much transplacental of the chemotherapy. So paclitaxel is unlikely to get there. We know some of the carbo we get to the baby, but it's the safest we have so far.
Thank you. That was what we thought at the time. Our decision was based on the safety of this regimen, based on mainly breast cancer patients. So our first cycle was done on July the 8th, and after that, the patient was discharged from home. We planned readmission 3 weeks later for a fetal evaluation and the second cycle of chemotherapy. But the night before the second cycle, she had a placental abruption and had to went a cesarean delivery, urgent cesarean delivery. So the chemotherapy was withheld, and following her delivery, the baby went fine. She was submitted to a neurosurgery reevaluation with the indication of the spine stabilization with this procedure of laminectomy or arthrodesis from T10 to L4, an extensive procedure.
There's a lot of bone disease and a lot of it needed to be stabilized. That's so scary, poor lady.
Yeah, the neurosurgeon was concerned about the movements of a mother with her baby and the instability of her spine in the situation. After that, we received her molecular tests that showed an EGFR mutation with an exon 20 insertion and some other molecular findings. And at this time, we was able to perform a PET-CT that showed hypermetabolic lesions on her lungs, multiple small nodules on both sides, and also in pleural surfaces, and extensive lesions on her axial and appendicular bones. Receiving her molecular tests, what would you do systemically at this point, Dr. Flores? Please.
So for exon 20, we know that immunotherapy benefit is limited. So I think the paclitaxel, carboplatin, bevacizumab is adequate, but the NCCN guidelines say that you can use immunotherapy. So there is no contraindication. But I usually don't use it because exon 20 insertions don't have a great response. But I think this is the IMpower 150 regimen. That's what you're using, which I think is fair, right? There is no data out there besides the one I'm publishing soon or what to do. Here, we do the best we can with what we have, which is very limited. So I think the treatment is appropriate. I will consider if she has any side effects to the immunotherapy, don't feel bad about stopping it because the benefit is limited for exon 20. It's not as bad as for, EGFR traditional mutations, but I think it's fair. Bevacizumab dose has benefit in exon 20. Did she have any complications from bleeding after the C-section with the bevacizumab or not?
No.
Okay. That's good.
She did it very. In fact, we withhold the beva in our first cycle of treatment. Her first cycle, she was on paclitaxel, carboplatin, and atezo. And in the second cycle, we put on beva also.
Yeah, and there's benefit in exon 20. I even my patients with exon 20 have liver disease and no contraindication for bevacizumab. I do it. I think it was a good drug, but then we all get so excited with immunotherapy that we forgot about it. So I think bevacizumab is coming back up to regimens.
Yeah, well, we discussed it a lot to put or not her on atezo at that time, but the decision was that.
I think it's fair because there is no data about pregnant women with exon 20, right? So
yeah.
Can I do a question?
Yeah.
Dr. Flores, here in Brazil, we need 21 days to obtain our NGS results. In your place, how many days?
So for these young women, we have we're very fortunate, right? So I'm in Dana-Farber. We have an EGFR center. We see the most EGFR patients in the US and probably America and Europe. So we have a rapid EGFR that comes back in 48 hours. The rapid EGFR, and then we have the rapid ALK and ROS that comes back in 3 days. But that's in this very unique setting. When I was at Mayo Clinic, it took around a week and a half. So even at the Mayo Clinic, I think here at Dana-Farber is because we see so many EGFR. I think that's the reason. But yeah, for my pregnant woman, I can get it in 2 days, EGFR, and then Alk and Ross 3 days.
Thank you.
But the other ones take a little bit longer. And the problem, and I think this is something we need to talk about, the problem with liquid biopsies is that pregnant women have fetal circulating DNA. So we have no idea so far what is the contamination of that fetal DNA and the liquid biopsy. Potentially, there shouldn't be any, pathologic lung cancer mutations in fetal DNA. But we don't know, right? Because all liquid biopsies were done in no pregnant woman. So yeah, it's very interesting. I collect liquid biopsy in all my pregnant women, and I'm following them prospectively to see if it changes after they deliver the baby, which I don't know yet.
Very interesting.
Yeah.
Well, after 4 cycles of Empower 150, she did very well with a great clinical improvement, no relevant toxicity. Her PET-CT showed a very good partial response, and on brain MRI, 2 small asymptomatic lesions were identified. At this time, would you consider brain radiation with radiosurgery, or would you keep on systemic treatment once the regions were small and asymptomatic?
I think that's a tricky question because all the drugs that you have, we do know that TISO and bevacizumab gets into the brain because we have the TISO brain data, right? That's one of the few very good data about immunotherapy in the CNS. A lot of patients with brain lesions were excluded for all of the immunotherapy trials. So they're very small. I will watch them. But if she progresses, you're going to move to potentially amivantamab. And that one doesn't get to the brain. So at that time, it would be a different conversation because if the lesions grow and amivantamab, then she needs radiation. But you have Bev and you have a TISO. So they're very small. I will watch them. We MRIs every 6 to 8 weeks. I won't wait for symptoms because younger women can have a lot of brain lesions before they have symptoms. But I don't think I would do treatment. I don't know what you decided to do, but that would be my call. But after they progress in chemo and they go to amivantamab, I will radiate them.
Well, we also choose to follow up these small lesions and moved on with Beva and Atizo. So at February 2021, she was on complete metabolic response on her PET-CT, but her brain MRI showed a slight increase on both lesions. So at this time, Marta went on the case. Would you like to comment something?
Yeah, that would be great, Marta, to hear about, hey, former pregnant patient, what can you do?
I have the feeling, and the question that Guilherme posed to you is a question that we are doing. We are receiving less and less patients with small asymptomatic brain metastasis of lung cancer. I understand that we have many active drugs that we didn't have, but on the other hand, it's not the case of this patient because she's exon 20, but we have data of patients, retrospective data of patients with asymptomatic lesions with other mutations, EGFR, that what the studies show is that the patients that receive upfront radiosurgery have a better overall survival. And it's a big difference, more than some drugs. And then sometimes I ask myself, sometimes the patient is, like Elena told here, in meanwhile waiting for the results that will define systemic therapy. And I favor treating with radiosurgery some of these patients because we don't know the answer. This patient was treated at this time because she was really stable and we didn't want to stop anything otherwise, and she was asymptomatic. So this was the decision at the time.
I think of what, if they were slightly growing and she has a good response, you're not going to, a good systemic response. You need to keep that systemic response. So treating the brain will allow you to stay in that treatment, because BEF and atezolizumab are better to tolerate than amivantamab, right? So I think I will have done exactly the same. And also, what is unique to younger women is that they also like to be very proactive, right? She just has at that time, I don't know how old was the baby, 6-9 months. So they want to do a lot, because all my pregnant women that are not pregnant anymore really want to do a lot. And it's understandable, right? Because some of them there is nothing harder that I have done in my life than making a patient hospice, like talking about hospice when they're holding their babies. It is one of the hardest things I have done. And I do a lot of hard things. So I think this is the right thing to do. But it's so hard when they still have babies that they were delivered during the cancer treatment.
Well, some months later, on July 2021, she finally progressed on lung, bone, and adrenal gland. At that time, we did not have the approval for amivantamab yet. She also progressed in the CNS. So at that time, we decided to put her again on a platinum doublet with pemetrexed and carboplatin, waiting for the approval of amivantamab.
That's fair, because it's longer than 6 months compared to when she has disease. And there is new data. These patients are going Keynote 189, carbopemetrexed and pembrolizumab. After 2 years, they're still on that therapy and they have progression. There is upcoming data that you can recycle the carbo and the pemetrexed now. We didn't do that before because people didn't leave that alone, right? So immunotherapy keeps them maintained for a little bit, and then the cancer eventually grows in the immunotherapy, and it starts to, like, I told my patients, we're going to restart the switch again.
Yeah, and in fact, she did it very well again. So she had a very good response on her PET, also in brain MRI. She continued on maintenance pemetrexed. I'll move on. She had a new radiosurgery for brain lesions during this time, until she again looked for our emergency department with intense headache, dizziness, and this brain MRI. Important increase in the edema and also on the lesion in her right frontal lobe. We discussed a lot these images, and the impression was radionecrosis. We put her on steroids, and she improved very quick. She just wanted to go home to stay with her kids. And after 2 days at the hospital with steroids, she was good and went home. And this was her follow-up brain MRI some weeks later. So
that's very good.
Yeah, we tapered the steroids, continued on pemetrexed, but in May she progressed again with bone disease, symptomatic bone disease, and at this time we changed her treatment to amivantamab. Nowadays, mobocertinib is being approved also in Brazil. If you could choose between amivantamab and mobocertinib, do you have a preference for one or another?
Yeah, I do prefer amivantamab. So amivantamab tends to have a MET inhibition on top of the EGFR inhibition. And we know that the most common mechanism of escape for EGFR is MET amplifications. So I like amivantamab because it kind of covers that resistant mechanism. Also, the mobocertinib diarrhea is hard to control. I know as pills, but we have more data about amivantamab. And there's some new data that was just presented, I think a month ago, at the European Lung Cancer Conference that compared amivantamab to mobocertinib, which it shouldn't be done, but it was done. They have patient individual data that showed that amivantamab can potentially have a greater benefit. The problem with amivantamab is the reactions to the infusion, right? They get red like a tomato. Around 65% of patients get their reaction. And that is an injection, right? At the beginning, it's weekly, and then it's an injection. Patients have to come down. But data suggests that it's a superior agent because of that MET inhibition that mobocertinib doesn't have.
In this moment, do you think about rebiopsying this patient?
I do believe in rebiopsies at the time of progression because you can have an idea what is the escape mechanism in these patients. But exon 20, we don't really have a lot of options, right? So what if she has a MET amplification? Well, she goes on amivantamab, which is the most common. I did see it in one of my HER2 patients, and one of my exon 20 patients, a HER2 amplification, no mutation. So it wasn't that helpful. And also, you cannot mix trastuzumab deruxtecan with amivantamab. It would be too much, right? It would be an inflammatory cascade for these patients. But for other patients besides exon 20, I really favor mutation, rebiopsy, because I tell my patients it's not only treatment, but it's for us to understand how these resistant mechanisms are developing. Because before, we didn't know that MET amplification was the most common mechanism of resistance. Now we know, right? And we didn't know before that T790M, let's bring a few more years back, the T790M was a mechanism of resistance until we started biopsying a progression. And that's how osimertinib came around, right? For that resistant mechanism. And that what osimertinib is a superior drug in this first line now because it inhibits the resistant mechanism. Same thing with amivantamab. The thing with amivantamab is that it's a few years behind, and that's way more toxic than osimertinib, right? The infusions are very scary. I educate my patients a lot, but I still get phone calls with the nurses saying like, oh, tachycardic, breathing very fast, it's turning all red, right? So it gets better, significantly better after the first infusion, but is still more challenging to do amivantamab, but it is my preferred choice.
There is a question from the chat whether we stopped pemetrexed during the central nervous system radiosurgery in this case of the radionecrosis. We withhold pemetrexed for a few weeks for the CNS radiation, but soon started again.
And there's some data that you also, in some patients, you had a very quick response. But in some patients, and Marta, I would love to hear from you, in some patients that don't respond to the steroids, sometimes we use bevacizumab or Avastin for the necrosis. But in the patients that, these patients respond quick, most don't. So we also use that in necrosis because it's a reality now because patients are living so long that you end doing radiosurgery multiple times. Right? Before that wasn't a problem. Now it's a good problem to have, but it's still a problem.
Yeah. So moving on, she unfortunately did not respond to amivantamab
at all. Oh.
Yeah, and we had to move to docetaxel and ramucirumab with some clinical improvement and also imaging improvement. But at the end, she came to the ER with hemorrhagic shock, bleeding from several liver lesions. She went to surgery, but it was not possible to to stop the bleeding, and she ultimately died on December 21, at the last day of last year.
This has been a very hard case. It's very hard because the kid is only 2 years old, right? And
Yeah.
it is really hard. And something about young women is that they take treatment. They can take treatment, right? She went through 1, 2, 3, 4 lines of therapy.
4 months.
And that's why we had these complications, because they can take treatment and they become highly. I have a patient that has been with me for 8 years, right? And they can take treatment, and that makes a lot of things more tricky because they're so young. And they want to keep going. Right? I think when we have older patients, they're like, "Oh, I had a good life," but when they're young, and you know, you look at their labs, and their labs look good, right? Despite giving it all the chemo, I'm pretty sure before she died, her labs still look good. So it is very challenging, but thank you for sharing this. I'm actually going to email you after this to include this patient in the registry. So.
Okay, to be a pleasure.
I don't know if we have some time for a question about your line of research in your lab. Can you talk a little bit what you are doing? How here in Brazil we can participate of this, because we think we are young women too. Let me know, of course, but we
it's
are.
So scary. It's so scary. And men too. It's so scary. Like,
so I'd like to know more about this.
Yeah. So one thing is the registry for pregnancy and lung cancer that we have. Any women that have been diagnosed with lung cancer when they're pregnant. Not that they got pregnant and that after they were diagnosed with lung cancer. Diagnosed with lung cancer when they're pregnant. We have a registry. Tercia from Salvador added a case. I'm working with her. I think I know Brazil so well now, thanks to everybody. And now we're going to add these cases. We have cases for Italy, Da Lorenza, Landi added. We have cases for Christine Lovely from Vanderbilt. So we're building this large registry to understand. Another research I'm doing is the liquid biopsies in the pregnant women. One of the issues with this is that a lot of pregnant women come and see me. They get their recommendation and they go back home because they don't live in Boston. We're also doing a study that we just got funded last week, and it's to understand the delays in younger women with lung cancer. So we are interviewing the women to understand what happened during this, because we don't have no idea how their experience is. We do know that a lot of them go in many cycles of antibiotics and steroids and all of that, but also what happened. I have younger women that have mammograms before they have a chest X-ray. Like when they come to the doctor. So we're trying to understand what's happening there. And of course, the fertility study. We can talk more about that when it launches. But we were happy to collaborate with you for the fertility study. This is a prospective study that we're doing because now that we have adjuvant immunotherapy, these younger women with melanoma and lung cancer are going in immunotherapy for a year. And we have no idea if they can get pregnant after that or if they become menopausal. We have no idea. So I think that's one of the few studies that we can collaborate. I cannot say much, but there's a big theme coming out for a consortium for women with lung cancer. So that one is at the end of the year. So I will let you know when there's more solid information. But it's time. The time is today to make sure that we are aware of this. And I can tell you now, after you have this patient, Guy, every time you see a younger woman, you're going to be like, is this lung cancer now? So it changes forever. It changes you forever. When you take care of a pregnant woman with this disease, it changes forever.
Yeah, it's interesting because it was my second lung cancer with EGFR is 20 exon 20 insertion in a pregnant woman in a few years. 2 cases.
We have 2 cases for the registry now.
Yeah, the first one was a colleague, a medical oncologist.
Oh my God.
Yeah.
Well, then yeah.
It was
That's the
very
hardest one.
dramatic. Yeah.
Yeah.
Both of them was exon 20 insertions. I will ask you do you know any relations with the type of mutation occurring during pregnancy?
What we know is whether we have seen a higher frequency in the EGFR, but it has to do with the sample because it's the most common one in younger women. But we also saw a high frequency of ALK, and ALK is very rare. So we have seen a high frequency of ALK as well. Exon 20, I have one patient only that was pregnant with that. But a lot of ALK, a lot of brain issues with ALK, as you know, when they're pregnant. I had a patient that had multiple brain lesions. We couldn't do anything. And she wanted to deliver the baby. And I was like, no, you cannot push this baby with this many brain lesions. That's going to increase. I'm not taking that chance. We're going to C-section because, she had many brain lesions and you cannot do the TKIs when they're pregnant because the TKIs highly likely will cross the placenta. There's some data that some TKIs may not, but I think it's too risky to say, oh, let's give you a TKI and see if the baby ends normal when we know that carboplatin and paclitaxel will buy you that time and you will be able to do it. I don't take the risk. There are case reports of people taking alectinib during pregnancy, but I think it's too much to lose, knowing that chemotherapy can be biostine and is safer. I think maybe in 10 years, we're going to be like, oh, yeah, give them the alectinib. But right now, I think it's no safe because we don't have data. And if the alectinib gets to the brain, it gets to the placenta. So, yeah. So that's the summary for the TKIs and pregnancy. We still don't know. So I usually do chemo. And I have been outside of delivery rooms with the bottle of the pills, waiting for the baby to come out. And I'm like, it's all good? We're all good. Here, pop your pill now. Literally waiting outside for them to take it because when they have these mutations, they will respond to the TKI. But just the baby needs to come out. So I usually have a calendar waiting for babies. It's like, oh, is the baby out? When is the baby coming out? I never thought my career was going to be like that. And last night I was called for a hospital in Nebraska. We are pregnant women with lung cancer. And the ER doctor's like, what do we do? I was like, well, okay, let's find out what we're going to do with this. But this is great. This is a great discussion. I really enjoy it. Sorry about the case, though.
But we learned a lot, for sure.
Yeah. It changes you forever.
Yeah. She's not my patient, and I suffer with Guilherme and Marta too.
Yeah, it's hard. And I told you that nobody prepared me to make my patient hospice when they're holding their baby. That's something that nobody in training prepares you. Nobody, there's no way somebody. And breast people have more experience for lung cancer. No, and now because I'm the person, these women come from everywhere. So every clinic, I'm like, how many pregnant women? And everybody's like, that my clinic looks like an OBGYN practice. But it is my honor to treat them when they need us the most.
When I first saw you talking in São Paulo, and I told you this before, I was blown away by the way you talked. And I started to remember, I don't know why, Guilherme, you have so many young women patients with non-small cell lung cancer, and some of them are having radiation with me. And then that motivated us to talk only about this, because it's very challenging, as you talked, if we have those patients gets in our mind and we don't forget.
You know what we're going to do? Because, I believe in this moment. So we should record a podcast about this for ISLC. We're recording one for somebody I met in Rio when I was there. So we should record a podcast about this, and let me pitch it to ISLC to see if we can have a session in 2024. This year, for 2023, the program is already out. But I think it will be very important. So thank you. And you're going to hear from me. I think we should do this podcast because we learned so much from each other today. And this is in Brazil, but I think we should expand it globally so people know.
Thanks to you. And Bruna was writing to me before the event, asking about other cases. And I said, in this event, no, but we can program. We have more cases, Guilherme. We have more cases to come if we want to make a discussion based on clinical cases. We have very interesting cases of long-term survivors with lung cancer. And we would be delightful to share it with you also.
Yeah. That's wonderful. So I unfortunately have to head out a little bit. I have an event to have to go, one of my patients' funeral. But if there is anything else, this is a great discussion for everybody. I'm happy to be reached by email. I'm not that great with WhatsApp. Bruna knows that. But I'm great with email, but I also have WhatsApp. I just not very good at it. We're more email people here, but it is my pleasure to be here, and I will be reaching out. Is there any other questions for the audience? Anybody else before we kind of end it?
No. Thank you very much for your
Obrigada.
talk.
We enjoyed a lot. Thank you.
Enjoy a lot.
Obrigada.
Good night.
Thank you very much.
Boa noite.
Thank you. Ciao.
Tchau.
Tchau, tchau.
A AstraZeneca vem atuando e transformando o padrão de tratamento dos pacientes com diferentes tipos de câncer de pulmão. Em 2011, inovamos com o Iressa. Em 2017, lançamos o Tagrisso. Em 2017, é lançado o Imfinzi. Em 2018, o estudo Flaura embasa uma nova aprovação de Tagrisso. Em 2019, através do estudo Caspian, Imfinzi ganha nova aprovação. Em 2021, com o estudo Adaura, Tagrisso é aprovado para estágio precoce. E essa história continua. Nós, da AstraZeneca, seguimos buscando ainda mais soluções para cada paciente.